For the sake of time احنا الحمد لله الجلسة دي خلصت في ميعاد مظبوط جدا. ان شاء الله نحاول نمشي on time. فانا هبتدي بعد اذن لغاية ما الشير بيرسونز يحضروا. النهارده بصراحة معانا one of the most eminent and most important authorities في pleural diseases, Dr. Najib Rahman. We will be delighted to hear his talks, and it's a pleasure and honor for me to share a session with him.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure and honor to be here. Ana Asif, my Arabic is terrible, mushkil for me, so it will be in English. I do apologize. Thank you to the ESSB and thank you to my friend Ahmed for inviting me here to give these two talks. So my first talk will be on pleural infection. We will today review proper diagnosis, microbiology and antibiotics, outcome prediction, and then invasive treatment options. And this is familiar to all of you, of course, the typical chest radiograph seen here on your left, a thoracoscopic view of pleural infection here with multiple septations and multiple areas of loculation, and then the typical CT scan. So this is a difficult disease to treat, as we all know. And since the time of Hippocrates, since 4,000 years BC, we know that the correct treatment is drainage of the infected material and also antimicrobial therapy. And within drainage now, we have, of course, closed tube drainage. Sorry, my pointer's not working, I don't think. This one, maybe. Yeah, closed tube drainage, but then adjunctive therapies to closed tube drainage, such as intrapleural agents, and finally surgical debridement and management. But all of them achieve the same thing, which is drainage of the infected material. And this is a big problem. I've given data here from the US and the UK combined, 1.5 million cases of pneumonia, of which 40% develop a parapneumonic effusion, of which 10 to 15% develop frank pleural infection. So in the UK and US, and the figures are similar for Europe, around 80,000 new cases per year. So this is a huge burden, not just in the early diagnosis, but then when they become frankly infected, they become a problem for you and me as pulmonologists. And the big problem is that the outcomes are very bad. Now, all of this data is modern data. This is not historical data. This is data from Europe from 2015. Mean hospital stay 2 weeks, surgical rate 15%, 35% in higher risk groups, and a mortality of 15% at 1 year. And to our shame, this has not changed in the last 20 years. You compare it to pneumonia, compare it to myocardial infarction, the mortality of these diseases is decreasing. The mortality of our disease is the same or is increasing. And as I've said, this is modern data from the UK. This is David Arnold, who works in Bristol, who surveyed UK practice and came up with exactly the same figures as we have seen over the years, unfortunately. So let's ask a few questions then. Why do some patients get pleural infection? This is not very well known. It's not well understood. In fact, I think the best data comes from a colleague of yours who's Magid Hassan. Magid came to Oxford and did a fellowship with us. And in 2019, he published this systematic review. This was published in the ERJ. He looked at 275 studies, 77,000 patients. And the key thing is that 70% of your patients with pleural infection have a comorbidity that we would recognize. But this means that 1 in 3 patients are completely normal at baseline, and that is interesting. So we should do more research on those patients who have no underlying disease and understand what is their immunological barrier that causes pleural infection in them. And this is the data from Magid's work. So as you can see, the vast minority have chemotherapy or steroids as an immunocompromise. The majority had hypertension, chronic kidney disease, diabetes mellitus, and this is generally well known. And then interestingly, the majority, nearly about 45%, were smokers. This has not been recognized before. We have a theory that maybe smoking alters the bacteriology within the mouth, and maybe this predisposes you to pleural infection. But if you want to read a good summary paper, then I would recommend Magid's paper to you. Now, accurate diagnosis. The earlier we diagnose the disease, the better the outcomes are. So it's important that we understand exactly how this works. This is from the BTS guidelines 2010, and this is still the format that we are using, although I will update you on the 2022 guidelines at the end of this talk. So we take patients with a pleural effusion, we sample the fluid under image guidance and divide them into these three categories. Macroscopically purulent, this needs drainage. Microbiologically positive, this needs drainage. And then the non-purulent, as is famous now, we sample the pH into low versus high. A low pH is complicated, becomes drained. A high pH is simple, doesn't need drainage. But let's think about what this data was based on. So this data that we all practice on is based on this one study. This is Hefner's work from the early 2000s, a meta-analysis looking at the pH of 7.2 as a predictor of a poor clinical outcome. But in fact, this data is based on only around 40 patients. So Richard Light, he said the pH less than 7.2 is important, and it has become embedded in all of our practices on the basis of a very small amount of data. So I think it's a good marker, we all use it, but it is not 100% sensitive. You will all recognize the ROC curve here. The top left, the white, means that it is not sensitive in this area. So the first thing to say is if your patient is doing badly, you should disregard the pH because they may be in this top area here. The question is, can we do a bit better? Can we be more biological? The pleural fluid pH is a reflection of the metabolic activity of the pleural space. And so that means that an advanced malignancy or esophageal rupture, the pH will also go down. Can we use something a bit more biological? And I think we have two areas that may become exciting in the future. So the first is this. So this was David Arnold and Nick Maskell in Bristol. They looked at SUPAR, which is soluble urokinase plasminogen activator receptor. So this is one of the key components of the fibrinolytic cascade, which they measured at baseline in patients with suspected pleural infection. And this is what they found. So let me just explain the graph. On the y-axis is the SUPAR level. On the x-axis is the pH level, and they divided patients according to CT into non-loculated and loculated. And you can see that the pH has no relationship with loculation whatsoever, whereas the SUPAR level, if the SUPAR level was above about 35, all the patients were loculated, and below this, they were not loculated. So this looks like a better biological predictor for what we see radiologically. It was also a better predictor of poor clinical outcomes. So here is the same ROC curve, pH, glucose, LDH, they're not bad. SUPAR appeared to look better than any of these three. So maybe we should be using SUPAR. Now there's a big methodological problem with this study, and that is that the clinicians in this study were using pH to decide who needed to have a chest tube. So maybe SUPAR is just a very expensive pH. We don't know that yet, and we need some more prospective studies to tell us the answer. And then my group, Ihab Badawi, who is doing a fellowship with us, he's now published on PI1. PI1 is plasminogen activator inhibitor 1, so it's an inhibitor of the fibrinolytic cascade. When infection comes into the pleural space, the PI1 levels go up, and we were trying to investigate what that meant clinically. And what we showed is, again, on the y-axis here is the PI1 level. We divided patients on ultrasound, blinded to the PI1 level in 230 patients into non-septated all the way up to heavily septated. And you can see that there's a linear relationship between the PI1 level at baseline and how septated they are. So we now have two markers, but most excitingly with PI1, we have now associated in this large study of 200 patients published in the Blue Journal this year, the survival with the baseline PI1 level. So if your PI1 level is low, then your survival is over 90%. If the PI1 level is high at baseline, your survival is more like 70%. And this has never been shown before. So perhaps we can use PI1 as a more accurate predictor than pH. Again, prospective studies are needed. And this is where we've ended up with the BTS Guideline 2022, which will be published, I hope, in the next few months. We will measure the pH. Low pH gets drained. High pH does not get drained, but intermediate pH, so 7.21 to 7.39, we will then look at the LDH and look at other factors, including pleural fluid loculation, large volume. So this is a bit more nuanced than the black and white high and low pH. Let's move on to microbiology. So this is the MIST-1 microbiology from Nick Maskell's study back in 2005, and this is well known now. The majority are caused by strep intermedius, a bit of strep pneumoniae, and some anaerobes. Hospital-acquired disease is completely different. And this again worked by Maged Hassan, who looked at over 9,000 cases in the world literature, and he showed again the same pattern. So Staph aureus viridans is the most common. Interestingly, depending on where you are in the world, Klebsiella can become a problem. So where I live in the world, Klebsiella is not a big problem causing pleural infection, whereas in the subtropics and tropics, it's quite a big contributor. And this matters because you need to decide on your empirical therapy at the beginning of treatment, because 40% of your patients have negative findings on conventional microbiology. You can increase this by placing pleural fluid within the BACTEC or blood culture bottle system. We proved that in this prospective study some years ago. It increases the yield by about 20%, even if you use very small volumes of pleural fluid. So this is something you can do every day. But what about something more exciting? What about molecular diagnostics? You will all be familiar with this from your diagnosis of TB. And we know that in pleural infection, 82% of culture negatives become positive with 16S, which is a PCR molecular technique. The problem is that it may be oversensitive, and no group to date has shown that it associates with outcome until this particular study. So this was led by Nick Kanellakis, who's the postdoc in my lab, and published in The Lancet just earlier this year. So we took 243 patients, we subjected them to metagenomics, which is a deep sequencing technique, and I'll just accelerate to the answer. The main finding was that pleural infection is a polymicrobial disease. So this was the patients who had a single metagenomic bacteria as the cause. This was 51 out of 243, whereas all the other groups, which is 3/4, had a polymicrobial bacterial entity. And this suggests that in the majority of cases, you need to continue with your anaerobic cover. And secondly, for the first time, we have associated the microbiology with the survival. So having an anaerobic baseline is associated with a better survival, having a Staph aureus at baseline associated with a much worse survival. We don't understand the mechanism of this as yet, but certainly if you diagnose a patient with Staph aureus, you should be very aggressive with your therapy. Okay, let's do a bit on risk stratification. Why would we wish to do that? Well, when I was training, I was told that septation, purulence, CT findings associated with a bad outcome, they needed more aggressive treatment. In fact, there was no prospective data at all until 2010. In 2010, Nick Maskell and I published this. So this is outcome prediction using 2 randomized studies, and we used baseline data with a known data set. And what we found was that these criteria independently predicted mortality retrospectively at 3 months. So we called it the RAPID score. And what that shows you is that a higher urea, a higher age, non-purulence of fluid, hospital-acquired disease, or a lower albumin at baseline, each of them was associated with a higher risk, total risk score of 7, and then we get risk categories of low, medium, and high risk. And does it work? Well, in the discovery set, it worked. So a low risk of 2% mortality, a high risk of 60% mortality. Retrospective validation, it's not as good as you can see, but it still seems to separate out low and high risk, 50% versus 2%. So this was very reassuring, but not the best data because the event rate here was quite low. We therefore needed to prove it prospectively. And my fellow John Corcoran then did this using the pilot study. So this was a prospective study of 550 patients recruited from all over the world, designed prospectively to assess the RAPID criteria. And this is what we found. It is incredibly powerful at predicting outcomes. So 3-month mortality, clear separation, and 12-month mortality as well. So the RAPID score really works very well indeed. And not only does it predict mortality, it seems to predict lung function at 3 months. So if you have a lower RAPID score, your lung function is better at 3 months. And very strangely, it predicts surgery, but in the wrong direction. So if you have the highest risk, you have the lowest chance of getting surgery. If you have the lowest risk, you have the highest chance of getting surgery. Now, there's 2 possible explanations for that. One is that surgery is saving people's lives. The other is that we're operating on all the wrong people. And we're operating on young, fit people who don't need it, and we're ignoring the elderly who have a much higher mortality. We need further studies to understand this fully. How do we now use the rapid score? Well, this is a key unknown. So this is a suggestion I have, which is do your pleural infection diagnostics, divide them into rapid score, and then maybe high rapid score gets direct surgery, maybe lower rapid score gets outpatient antibiotics. We are now planning a prospective clinical study. So for my last few minutes then, drainage and septation disruption. You'll be familiar with an ultrasound here with agitated saline showing a lack of movement of air bubbles between the septations, and this is a thoracoscopic view, of course, showing all this fibrin. It makes perfect sense then that we want to disrupt the fibrin to try to improve our outcomes. However, the largest, best conducted study, MIST-1 study, streptokinase versus placebo, double-blind, was completely negative, as you all know. Lots of people were unhappy with this result. I wasn't. This was a very well-conducted study, and it showed it didn't work. There were lots of biological reasons to understand that streptokinase maybe was the wrong fibrinolytic, or that fibrinolytic alone was not sufficient to strip the biofilm and change viscosity, and we therefore went on to do the MIST-2 study. Now, the MIST-2 study was a combination of DNase and TPA as a modern fibrinolytic, double placebo, TPA placebo, DNase placebo, with a radiographic outcome. And this is what we showed. So just to explain, the 0 here is the line of no difference. So this patient over 7 days had no change in their chest X-ray outcome. This patient had a doubling of their chest X-ray shadowing, and this patient had complete clearance just here. And what you see very quickly is that placebo clears about 30% of the X-ray, exactly the same as TPA, exactly the same as DNase. If you put them together, you get a doubling of the drainage, and most of the patients in the TPA DNase group had complete clearance of their chest X-ray. Good. So what? X-ray gets better. Do we really care? Well, in fact, yes, we do, because the surgical referral with the TPA DNase group was 80% lower, and the time in hospital was reduced by 14 days. This is a hugely effective treatment. Now, these were secondary outcomes, but nonetheless, it seems to affect the underlying disease as well. So what should we do with the MIST-2 regime now? Should it be standard of care? In fact, although this is my data, I don't think it should be standard of care in everybody. We know that the X-ray gets better. It suggests it improves other parameters. When do I use it? I use it if the patient is not fit enough for surgical intervention. When I'm waiting for surgical intervention, this question is not answered. Is it better to give the MIST-2 drugs or to go to surgery? I'll show some data on that a bit later. Now, since we published this in 2011, there's been a lot of further data on the MIST-2 regime. We have shown that it's been cost-effective, at least in a UK health setting. So this is the likelihood of cost-effectiveness, and MIST-2 has a 90% likelihood of being cost-effective. People have done large case series. So this is Gary Lee's group, who published the first case series of 100 patients failing medical therapy. They gave them the MIST-2 regime. They had a 92% success rate and a low complication rate. The problem is this is a case series and is small numbers. So my colleague Ihab Badawi has now published this. This is the retrolysis study published in Chest this year. And in this study, we looked at nearly 2,000 cases of TPA DNA from around the world. And overall, we demonstrated a very low bleeding risk. But the study was big enough that we can now start to predict who is likely to bleed. So if you're on anticoagulation, if you had renal impairment or a higher rapid score, all of these were associated with a higher bleeding risk. Not only that, but we now know that around 12% of patients having the MIST-2 regime have significant pain. So we consent them for this and in fact give them morphine before. And there are a few other complications. So we're learning more about this intervention. But if we look at the bleeds, so this is all of the bleeds in total, 50% of them were dealt with just by a blood transfusion. Only 1 in 4 needed surgical intervention. So we can say with confidence that 1% of MIST-2 treated patients need an intervention. This looks like a very safe thing to do. Now, since we're pulmonologists, let me just talk about medical thoracoscopy for pleural infection. There is one randomized trial. This is done in the States, KIA. It was very small, unfortunately, and they were looking at length of stay of the MIST-2 regime versus medical thoracoscopy. And they seem to show a shorter hospital stay with medical thoracoscopy than with the MIST-2 regime. No differences in anything else. But there's a big problem with this study, which is methodologically that they did the wrong thing. So they measured outcome from the point of intervention, not the point of randomization. If you look at it from the point of randomization, there was in fact no difference. And in fact, it was a very small study. So I'm not clear that we know medical thoracoscopy is better than MIS2. If you don't have access to TPA DNAs, you should think about large volume saline flushes, 250 mils normal saline 3 times a day. This trial by the Bristol group showed that it appeared to reduce the need for surgery by about 50%. So if we can't use MIS2, we tend to use irrigation. And then finally, what about the role of surgery? Well, no question that we need to operate in some patients, but who, when, and surgery up front, these questions are simply unanswered. There are 2 randomized studies seeming to show that upfront surgery in very small numbers of patients seems to result in better outcomes. But methodologically, there are major flaws with these studies. So they're highly selected populations, no blinding, and very high failure rate in the medical arm. I would remind all of you that with your treatment, 70% of patients get better with medical management. So the case for immediate surgery has simply not been made. My final 2 slides then. TPA DNase looks like it's safe. We don't know quite where to use it in everybody. Surgical intervention, its early role is unclear, and we have just completed the MIS3 study. I won't show you data on this, but we were comparing directly early VAT surgery, DNase TPA, and standard care. Please look out for the paper. It should be published in the next 4 months or so. And just to end on the BTS guideline, this is now what we have recommended. So if you've got pleural infection, calculate the rapid score, use a small bore chest tube, and after 48 hours, decide if they are doing well or badly. If they're doing well, just carry on. If they're doing badly, then consider whether, I'll just start the thing here again, consider a thoracic CT scan. Are they a surgical candidate? If they are, surgery. If they're not, then TPA DNase. And if this fails, then back into surgery. So we've suggested much more aggressive treatment within 48 hours of your chest tube and antibiotics. So my conclusions, we have new biological parameters. The rapid criteria works. Fibrinolytics alone don't work, and you should use them with DNase. The role of TPA DNase is unclear. I use it in patients who are failing therapy. Surgery is essential, but we need a bit more data as to whether we use it in everybody up front. I must thank all of my collaborators, including Egyptian colleagues who are here in the audience, and thank you for your kind attention.
Thank you very much, Professor Najib. It's a wonderful presentation, and I wonder how much is the cost of TPA and DNA injection. I mean, it should be very expensive.
Yes, thank you, Professor. It is expensive. In the UK, it is in the region of 1,500 euros for a treatment course. However, that's for both the TPA and the DNase, and the TPA is the expensive bit, actually. In the US, it's about $2,000. That's the reason we did the health economic analysis. And even with that cost in the UK, it was cost effective because it reduced hospital stay by so long.
The average duration of keeping the tube in, how long does it take, the average? A week, less than a week, few days?
It's a brilliant question. I think without the TPA DNase regime, the average tube dwell time is 7 to 10 days, so it's long. If you use the MIS2 regime, you can shorten that to 4 or 5 days. And in fact, in modern practice now, if I give TPA DNase, I will then do an ultrasound the next day. And if there's no more pleural fluid, I just stop giving it. So we don't just keep giving it. So we can shorten the course as well.
Thank you very much. Thank you very much. I will keep the questions at the end of the session. And may I introduce my dear colleague and friend, and he's the major pillar in our bronchology society, Professor Ahmed Al-Halfawi, and he's going to address for us the advances in diagnosis of pleural effusion.
Thank you very much, Dr. Tariq. First of all, thank you all for coming, and thank you, Najib, for accepting the invitation and for the excellent talk. It's a very big challenge for me to address diagnostic techniques in the presence of Najib, but so I thought, well, I'll keep it the advances, only the hints about what's going on, and he can comment afterwards since he's published half the data. So my talk about undiagnosed pleural effusion, unilateral pleural effusion. The diagnosis starts with a good history, taking a physical exam, radiological exam, studies, chest X-ray, ultrasound, CT, PET, and MRI. And then if we don't reach a diagnosis, sometimes we can reach a diagnosis at this stage, and if not, then we move on to aspiration, which will identify if or confirm if it's a transudate or exudate. We will have chemical analyses and cytology. And then if no diagnosis is reached, then we move on to pleural biopsy. We owe a lot to this man, Dr. Richard Light. He passed away last year, but we have to remember him in each session of pleura. So unilateral pleural effusion, needing diagnosis. This slide is very nice because it shows that some people, we don't have to do more. People who are comorbid, who have a lot of comorbid conditions, just treat symptoms. Patients who are terminally ill, malignant pleural effusions, we don't need to intervene and put in drains, do the minimum. So if their etiology is unknown and the patient is unfit for further investigation, do an aspiration, put a small drain, and leave. If it's fit, then we move on to diagnostic procedures. First to determine whether it's an exudate or a transudate. Look at the cytology. If it's positive cytology for malignancy, then we look again at the performance status of the patient. If he's fit, then we can go on for thoracoscopy. Transudates are not our major concern, but we will concentrate on the unilateral exudative pleural effusion. Radiology starts with used to be the chest X-ray. Now we have ultrasounds in all our units, so transthoracic ultrasound is number one. And in fact, it has changed the practice of pleura-minded physician over the last few years. It's now become a fundamental method for investigation to the pulmonologist. It's a bedside, non-invasive, it's a rapid, no radiation. It can detect the septations, and it can help in the later on assessment of successful pleurodesis. From the examination, we can determine look at some points that may predict malignancy, like pleural nodularity, a thick pleura more than 10 millimeters, a thick diaphragm, echogenic swirling patterns in the effusion, and we can also detect the small pleural metastases as circular nodular pleural-based lesions. And now, after the ultrasound, we think of effusion as a pleural thickening or effusion that has detectable on ultrasound, or is it just an effusion, there's no pleural thickening, or if it's a pleural thickening without effusion. We can easily do that now and then choose the method that we will go on for the diagnosis. The first step in diagnosis would be the thoracentesis to differentiate exudates from transudates, order all the tests that we want, but it has variable sensitivity in different causes. So in adenocarcinoma, it's different than in small cell metastatic disease. And the debate is about whether to repeat the thoracentesis or move on to another mode of investigation if the initial one is non-diagnostic. The usual tests that we order, and this slide I put in every presentation because this is underused method, and it can help us in choosing the type of procedure that we will use for taking a biopsy, which is measurement of the pleural manometry. Now, recently there have been very small devices that can measure the pleural pressure, but when we need, I use the old CVP method, the old manometer. Cytological examination in pleural effusion has an overall sensitivity on 40s to 50s. Higher variable results according to tumor type. So adenocarcinoma may be diagnosed in up to 80%. It also depends on the volume of pleural fluid submitted. Depends on the number of previous cytological examination, and the yield of malignancy increases when both cell block and the smear are examined. And we can predict mortality or performance of these patients using the Lent score or the PROMIS score. Dr. Najib has mentioned also the rapid in the infections, but the Lent score categorizes patients into low risk and medium, moderate risk, and high risk. So they're very useful. Tests are very easy, ready and available, but we have to implement. Now, a small test to detect or predict the presence of malignancy, the cancer ratio, which is the serum LDH to the pleural fluid ADA, and the cutoff value of more than 20 is higher predictive of malignant cells. So the more the value, the more the specificity and sensitivity. The newer cancer ratio plus, it's the cancer ratio to the pleural lymphocyte count. Cutoff level of more than 30 is highly predictive of malignancy, as you see in the graph. And these tests, we can all calculate these ratios, but I think few of us do. We all send the specimens for cytology and pathology, and they go back asking for immunohistochemistry. And as we know, the markers for mesothelioma, the most important would be the calretinin and CK56, the adenocarcinoma, the TTF1, and carcinoembryonic antigen. I think the future now will be on detecting the BAP1 loss in the effusion to diagnose malignancy. So BRCA-associated protein 1 loss or the P16 deletion would go in favor of malignant pleural mesothelioma. Pleural fluid now can be tested for driver oncogenes like the EGFR and the ALK using PCR and next generation sequencing. We can also test for PD1, PDL1 by immunohistochemistry. It requires a larger volume of pleural fluid. And these tests show concordance with surgical and resected pleural biopsy specimen. And as we all know, the trend now is liquid biopsy. We have a couple of talks during this conference about liquid biopsy. So liquid biopsy, they try to detect tumor-derived products in the pleural fluid, like circulating tumor DNA, non-coding RNA, and some other like extracellular vesicles. I think the future will carry a lot for these liquid biopsies. And maybe there are some analyses that using proteomic tests for the diagnosis of malignant mesothelioma, prosaporin and quiescin, they have promising results. Circulating microRNAs as biomarkers can be used for detection of malignant or diagnosis of malignant mesothelioma, and some metabolomics tests like higher levels of valine, lower levels of acetoacetate, they indicate that we're dealing with a malignant etiology. Also, the diagnosis of tuberculosis, this group from Italy, they looked at the role of internal mammary lymph node involvement in tuberculous effusion. So they say that up to 70% of patients who have pleural effusions and visible internal mammary lymph node would be tuberculous effusions, as compared to 40% in non-tuberculous effusions and 14% in control patients. You don't find these internal mammary lymph nodes enlarged. You can also look for some T helper subsets in the pleural fluid to diagnose the tuberculosis, the TREC cells, the CD4 positive interleukin 9 cells. These will be available in the future. We used to diagnose or order Gene Expert. Now the Gene Expert Ultra is a more sensitive and more accurate means of detecting TB in pleural effusion. Recent advances in pleural biopsy techniques, we go back to the Copes and Abrams needles. Now, after the ultrasound, some investigators have gone back who don't have thoracoscopy. Now, they have increased the incidence and the yield of diagnosis of these pleural diseases using the Abrams needle under ultrasound or CT guidance. So combination of techniques can get higher results. And also the contrast-enhanced ultrasonography. So now it's possible to inject a dye, and then the dye would be apparent on ultrasound machine that has harmonic contrast imaging, and the dye would concentrate in the active part of the lesion, not to avoid taking biopsies from the necrotic parts to increase the yield of diagnosis. The shear wave ultrasonography, we first heard of this ultrasonography in the EBUS ultrasonography to detect the firm and the hard lymph nodes. This is the same, but in pleural disease, you can detect the harder parts of the lesions to get the biopsies that would be more representative of malignant disease. And if nothing of these techniques would reach the diagnosis, then medical thoracoscopy, which is now the gold standard of pleural disease evaluation, highest diagnostic yields across all the etiologies. The rigid versus semi-flexible, it's still debatable, but I think it's for everyone's preference. The results are not different. I prefer the rigid, gives more access to cutting adhesions, but some physicians would prefer the semi-flexible. It's closer to the bronchoscope. The thoracoscopy can be diagnostic and therapeutic at the same setting. Now, if you take biopsies and do Rose technique on the touch preparation of thoracoscopic biopsies, you can get even biopsies diagnosis during the procedure. And if the biopsies are not very accurate, you can take more biopsies. But I think during the procedure, you find it's evident that it's malignant whenever you inspect the pleura. Tuberculosis can be also guessed if you have experience. The non-specific tests, these are the non-specific pleurisy, these are the ones that confuse us most. The rigid, the semi-flexible, and the mini thoracoscopies. We've seen yesterday a talk about cryobiopsy for taking for the pleural lesions, and yes, it gives more, gives larger biopsies, but there is no difference in the yield, and therefore it's not routinely indicated for biopsying lesions in the pleura. And this slide, so these are very old but recent techniques. The MBI and narrowband imaging. I've had a thoracoscope maybe 15 years ago that had this technology, but it's still underused. We need it in very selected cases where you're not very sure where is the part to diagnose. So this picture, of course, these are the lesions, but this picture I took to show the difference in the capillary, how they look like during thoracoscopy. Autofluorescence is also the same. principle where you can guide for the site of the pathology. Confocal laser microscopy during thoracoscopy has been investigated now, where you inject IV fluorescein and illuminate the pleura with laser, and it gives real-time in vivo imaging of at the cellular level, so you can inspect the cells, not only the gross pathology. It can also predict or detect visceral pleural invasion. And lastly, optical coherence tomography, OCT, is non-invasive technology using near-infrared light to provide high-level, high-definition, cross-sectional, near-histological images. So you can see the details of the cells during the procedure. Problem is the field of examination is very little, so to examine a large portion of pleura, it will take a very long time. I hope that in the future we will have these more advanced means of using such techniques for diagnosing of pleural effusions. This is a summary of how the diagnostic techniques would perform for diagnosing pleural effusions. So the cancer ratio is very sensitive. You see the pleural fluid cytology is not sensitive. It's as sensitive as blind needle biopsy, and thoracoscopy would be higher. So maybe with the advances in the chemical analysis of the pleural effusion, we can reach diagnosis more accurately. And my final slide, this is the advance that we would like all to have in our units, a unit with a combined MRI, PET-CT, 3D ultrasound at the same place. I think it would be very helpful for our practice. Thank you very much for your time.
Thank you, Ahmed, for an excellent expose on advances of pleural effusion. And actually, Ahmed Halfawi is our reference in pleural problems. I always refer to him, my problematic cases. But I think I'm going to shift to Najib Rahman. I will send him my patients after that. May I invite Professor Najib Rahman again? And he's going to give, we're abusing you this today, Najib. So on management of malignant pleural effusion, which unfortunately we see it a lot in our practice.
Okay. Thank you once again. So sorry it's me talking for a second time. We'll talk about the management of malignant pleural effusion. And Ahmed, may I say, I've thoroughly enjoyed your talk. It was a very thorough discussion of the diagnostics. So I thought for this, we would cover guidelines and then separate out some of the data on pleurodesis, IPC, combined procedures, and where we're going in the future. And I think it's really important as clinicians that we engage not just with the headline of the data, but the detail of it to understand how it applies to our patients individually. So I'll present quite a bit of data from my unit, but I will also criticize it as well. Malignant pleural effusions are well known to all of you. On the right, typical malignant effusion with huge amounts of malignancy, as Ahmed has shown you already. And I think we should remember this. This is a brilliant piece of epidemiology from Sri Mumadi, who works in the USA. And he did a simple calculation for the cost per year of malignant pleural effusions in the US. And if you look here up at the top right, it's 1.8 billion pounds are spent on malignant pleural effusion per year in the US. It is a huge amount of burden for all of us. So we've got lots of guidelines now. We've got this guideline from the ERS 2018, the ATS guideline from a bit further on. The ERS guideline is good at summarizing some of the data, but doesn't have a flow diagram, whereas the ATS guideline does have a flow diagram, and this is what the flow diagram looks like. And the bit that I just show you is this. So if the lung expands, then the suggestion is that we have a discussion with the patient about whether they want inpatient talc or outpatient IPC, and it's very much patient choice. And I think we should think about where the data for this comes from. And then let me share with you the 2022 guidelines that inshallah will be produced by us in the next few months. Here we have done pretty much the same thing. So we consider, is the patient likely to benefit from intervention? And then, is the lung expandable? If it's not expandable, we would definitely argue for IPC or therapeutic aspiration. I think we all agree on that, although the data here is really rather poor. And if the lung is expandable, then we suggest either inpatient pleurodesis or IPC, and then consider talc via the IPC. So what's the data that all of this is built upon? So let's start with pleurodesis, because pleurodesis is our old friend, isn't it? We've been using it for 50, 60 years. What's optimal pleurodesis? That means most effective, least side effects. And this study, I think, helped to define this area. So this was my PhD project, actually, the Time 1 randomized trial. What did we do? Why did we do it? Non-steroidals are extremely effective in acute pain. They are more effective than morphine for things like hip fractures in the first 4 to 6 hours. But me and you were taught that we should avoid non-steroidals in pleurodesis because they impair pleurodesis. When we looked at this in 2008, we found there was no human data, just 3 animal studies. So potentially we're all avoiding a very effective analgesic in pleurodesis. So that was the first question. And then the second question was on drain size. So big drain or small drain for the use of pleurodesis. There is one randomized study to date, 18 patients only, the Clemenson study. And actually there was a methodological problem here. This is a negative superiority study, not a positive non-inferiority study. So in fact, if you look at their pleurodesis rate, the confidence interval was 20 to 80%. This is a ridiculous pleurodesis success rate, I think. And so we were all basing our practice on the basis of very poor data. And therefore we did this study, which was taking malignant pleural effusion patients, and we randomized them in what's called a 2x2 factorial study. So this is a study where you answer 2 questions at the same time, and you randomize the patient firstly to a big drain or a small drain, and secondly to non-steroidal or opiate, having the outcomes of average pain score while the drain was in situ, and then pleurodesis success as a non-inferiority comparison at 4 weeks and 3 months. And we randomized 320 patients in 15 UK centres. And this is what we found. So over here this is pain, by the way, over from 0 hours to the time the tube was withdrawn. And this is the 100 millimeter pain score, so higher is worse. You can see that the 24 French drain is always more painful than the 12 French drain. So we've proven that bigger drains hurt more. No big surprises there. Between opiate and NSAID, not really much difference over time, but in that first 8 hours, the opiate was much less effective than non-steroidal. So for acute pain in pleurodesis, I believe that non-steroidals are much more effective. But did that interrupt pleurodesis success? Well, here's the Kaplan-Meier of pleurodesis success, non-steroidals and opiate, absolutely no difference between the two. And an overall pleurodesis success of about 80%. However, against my prejudice, I thought 12 French drains were just as good as 24 French drains. In fact, they're not. So a 12 French drain results in a reduction in pleurodesis of about 12%. And therefore, our surgical colleagues were right. A larger drain is better. And if you're going to do a pleurodesis, you should use a larger drain. Now, on the basis of Time 1, what do we say? Well, you can use non-steroidals or opiates. A large bore tube is definitely more effective. The large bore tube is slightly more painful, but you can handle that with some analgesia. Now, what about this question? Optimal talc delivery. This is a great thing to do. This is me doing a rigid thoracoscopy. I've taken biopsies. I'm now doing a talc poudrage, and it's a very satisfying thing to do. We spray the talc all over, get a nice covering on dry pleura, and there's 100 reasons to think that this would be more effective than a bedside talc pleurodesis. The problem is the data. So here is the first randomized trial, Dressler's study, very old, showing no difference between poudrage and slurry. There were some problems in this study. If you look at how many patients were lost over time, the final analysis was probably quite flawed, so we needed to do a better study. My colleague Nick Maskell led on this study, the TAP study published in JAMA. This was the Dressler study done a bit better, and once again showed absolutely no difference between poudrage and slurry. So although it's a fun thing to do, we now have 2 RCTs that show absolutely no benefit of poudrage over slurry. What does this mean? If I'm doing biopsies at thoracoscopy, I will do poudrage, But if I have a known MPE, I will not select them for poudrage. I will just do a bedside. It's very, very straightforward. Now, what about this difficult question? Perhaps we should stop messing about. We should give it to the surgeon. They'll do a nice pleurectomy. They'll do it much better than us. Is that really true? Well, we have one randomized study that suggests the opposite. So this is the MESOVAT study. This was only in mesothelioma. Robert Rintoul led this from Cambridge. And he randomized patients with mesothelioma to a talc pleurodesis, either thoracoscopic or bedside, so that's you and me, versus a partial pleurectomy at VATS, randomized 1-to-1. And guess what they showed? No difference in survival. VATS was longer in hospital, more complications, more expensive, and no difference in fluid control or quality of life. And this data says that you should avoid surgery in mesothelioma. For the rest of malignant pleural effusion, we don't know, and Gary Lee is doing a study in that area very soon. Now, what about this thorny question? Do you use the indwelling catheter, or do you use talc slurry pleurodesis? So we now have 2 randomized trials. This was Helen Davies. This is the first randomized trial in the literature from my group, JAMA 2012, the Time 2 study. And then with exactly the same methodology, Gary Lee's group did the AMPLE 1 study, both of them 1-to-1 comparison of talc pleurodesis versus IPC, and they show the same thing. They show no difference in quality of life or symptoms. There's a reduction in time in hospital with the IPC of 2 days in total. There is a reduction in the number of pleural procedures and an increased adverse event rate with the IPC. So if your patient wants to get home, then the IPC is probably the better treatment. A lot has been made of this. 18% reduction in pleural procedures. But let me criticize my own data. Is that the right outcome? The question we were asking is how often did the patient visit you for a further needle in the chest? But I think that's the wrong outcome. Let me explain why. Both Time 2 and AMPLE 1 show an 16 to 18% reduction in the need for further pleural procedures, but this is a physician-centric outcome. Let me explain what I mean. Here is a bit of work that Rochelle Ashiak did when she was with us in Oxford. She took our 180 patients who underwent an indwelling catheter over a 2-year period, and she just followed them until they died of their malignant pleural effusion. And what she noted was that 1 in 3 require an urgent further review that was not planned, and the patients drained themselves at home nearly 100 times. This is not the same as no further pleural procedures, and I think we need to remember that. Yes, I'm not going to have to do any more procedures, but the patient will certainly have to. So what do? I discuss the risks and benefits with the patient. I offer them a free choice, but I explained that in the majority, IPC is a lifelong treatment. I'll come back to that in a second. Talc is sometime in hospital but can fail, and patients are allowed to make their own choice. Now, let's say you choose to use an IPC. How do you manage it? Well, we now have 2 good randomized trials showing that you should increase the drainage frequency. So this is Momin Wahidi's great work, the ASAP trial, where they randomized patients with IPCs to either daily drainage or drainage once every 3 or 4 days. And they showed that with aggressive drainage here in red, you double the pleurodesis potential. Now, before we get too excited, just look at the pleurodesis rate at 6 weeks in the standard arm. This was down at less than 20%. And even with aggressive drainage, that's still less than 50%. So hence my view that if you use an IPC, even with regular drainage, the majority of your patients will have it for the rest of their life, and that needs to be consented for. Now, this study has been replicated again by the Australian group, exactly the same methodology and the same finding. So here you have a 20% pleurodesis success with aggressive drainage, you double it, and again, no difference in symptoms between the 2 groups. Now, Nick Maskell then came up with this idea. What about sticking talc into an IPC, so outpatient pleurodesis? And we randomized about 130 patients to either talc via an IPC or placebo via an IPC. I just point out that in this study, we first drained them for 10 days and we excluded patients with a trapped lung. So this was a highly enriched population. They had the best chance of pleurodesis. And what we showed in this study at 5 weeks was that you double the rate of pleurodesis from approximately 20% again to approximately 50% if you use talc. So that's great. It's deliverable as an outpatient. It's safe. It seems to be more effective than saline. Now, people have said this means that we don't need to do inpatient talc pleurodesis anymore. Let's just look at the data and let the data answer it for us. So this is the TAP study, the pleurodesis study. This is IPC+. If I look at the pleurodesis rate at the same time point, so that is here at 9 weeks and here at 9 weeks, in TAPS, the pleurodesis rate is 80%. In IPC+, it's 55%. There is no comparison between the two. You have a much higher pleurodesis rate. And not only that, but remember, TAPS included all comers, whereas IPC+ was an enriched population. So if you're going for a pleurodesis, the thing to do is to admit them to hospital and put a chest tube in them. These two are not equivalent in any means at all. So inpatient pleurodesis is still the most effective pleurodesis strategy. Now, perhaps we can increase efficacy. Perhaps we can combine everything. So we do a thoracoscopy for biopsy, poudrage, and then insert an IPC at the same procedure. There's a bit of data that is supportive. So Chuck Reddy did this case series of 30 patients in which he did a biopsy, put an IPC, did poudrage all in one day. And they stayed in hospital for a couple of days. They claimed a 92% success rate, and they removed the IPC within a week. That sounds very good. This study by Boujard, approximately the same number of patients, and again, approximately the same data, but their median stay was 3 days versus 9 days for historical pleurodesis controls. So we're not quite sure if this is worth doing, and Nick Maskell and I are now doing this study. So this is a tactic trial. We're about 50% recruited. We're randomizing patients to either poudrage pleurodesis and admission, or poudrage and IPC and day case, and we should have data in approximately 12 months for you. This is what it looks like. So we've taken biopsies. Here is the trocar. We'll then place the IPC first. Once the IPC is placed and in the right area, we then do the talc at the end and seal up the patient. And then finally, what about getting pleurodesis even better than it is already? The problem with pleurodesis, people tell me, is the time in hospital. So can we reduce it? And we came up with this idea of using ultrasound as a theranostic tool. And so my colleagues Yanis Salidas and Magid Hassan, they led on this multi-center randomized trial called the SIMPLE trial. Let me just explain what we did. So we took patients who needed pleurodesis with MPE. We randomized them to BTS standard care, chest tube, pleurodesis, chest x-rays, monitor the fluid output, or daily thoracic ultrasound during the period of their pleurodesis, looking at two things: how long were they in hospital, superiority, and non-inferiority for pleurodesis success with the same methodology. Now, what did it look like? As I've said, BTS guideline, you will be familiar with: chest x-ray and fluid output, bedside thoracic ultrasound guided management. Let me describe that. So every day, they had a 9-point thoracic ultrasound scan, so 3 lateral, 3 anterior, 3 posterior. And for each of these points, we scored whether lung sliding was present, equivocal, or absent. So your highest possible score was 27, that means complete pleural adherence. Your lowest possible score was 9, which means complete pleural slippage. And this is what it looks like. So this was a patient pre-pleurodesis. You can see on the B mode here, there's clear movement shown here on the M mode as well. So this would get a score of 1, so complete slippage. Whereas the next day after pleurodesis, in the same position, they look like this. So with the breathing artifact, there's absolutely no movement. This would get a score of 3. So we created a score and did the score each and every day. And this is what we found. So in this randomized study, we saved a whole day in hospital by using thoracic ultrasound. And you can see that the majority of patients in the ultrasound group went home within 1 or 2 days of pleurodesis, whereas standard care, it was only about 50% who went home at that point. So only 20% versus 40% went home on the first day using ultrasound versus standard care. So it clearly gets you out of hospital. The question is, does it reduce pleurodesis or does it increase cost? And in fact, it does not reduce pleurodesis. So this is a non-inferiority comparison. Here is the line of no difference. And we've got pleurodesis rates up at the 70% in both groups, no difference between ultrasound and standard care. And in fact, it was cheaper to use ultrasound by approximately £1,000. And the reason for that is that it saves time in hospital. So What do we conclude? We conclude that ultrasound-guided talc pluridesis shortens hospital stay. It doesn't compromise the efficacy of pluridesis. It doesn't worsen patients' symptoms or quality of life, and it is extremely cost-effective. And therefore, in my view, after this study, we should all be doing ultrasound on a daily basis. What we haven't answered yet is whether you need to do the full 9-point ultrasound or whether you could do just focused ultrasound in certain parts of the thorax, and we're doing that analysis now. Okay, so that's the end of my talk. Let me just conclude. In terms of malignant effusion management, there is no justification for surgical or thoracoscopic pluridesis as an entity in itself. If you're doing a thoracoscopy, it is legitimate to do a talc, of course it is, but you could even do it the next day with a slurry. There's no difference in outcome. To get the best pluridesis in hospital, you need a large bore chest tube, and you can use non-steroidals, that's fine. There is equipoise in our symptom management between IPC and talc treatment as long as the patient does not have trapped lung. And if you use an IPC, you should use what we call active management. So you should drain them more regularly, and you should think about giving talc as an outpatient. I think that ultrasound should be used for all pluridesis, and it may be that after the tactic trial, we can say that the way forward is a single combined procedure: biopsy, local anesthetic thoracoscopy, poudrage, and an IPC all in one go. So I'll finish there. I must again thank my colleagues, including several who are from Egypt. Shukran Gaziran. Thank you.
Thank you very much, Dr. Najib. Excellent talks as usual. Anyone has questions? We have a couple of minutes. Dr. Ayman.
First of all, thank you, Dr. Najib. We are all thrilled that you are here in Egypt and you don't have to travel to hear you. Thank you very much for being in Egypt and welcome to Egypt. And thank you for your elegant presentation. I have one comment and two questions. You said that the choice between enduring pleural catheter and talc poudrage, it's a free choice. Yes, I agree, but I think the culture and the social reasons that determine this. Did you agree with me? In Mediterranean countries like Egypt, Italy, Greece, they usually prefer the talc pluridesis, not in UK.
Yes, so Jazakallah khair. Firstly, it's an honor. It's my honor to be here, so thank you for the invitation. I agree with you 100%. And let me explain. I think it's too easy for us to say, I don't want you to spend time in my hospital, I want you to go away. And so we'll put a catheter in and you go home. Our purpose is not to get rid of the patient from our site. Our purpose is to serve the patient properly. And a big part of that is their culture, their home situation. Many of my patients have said to me, when I have offered them an IPC, I don't like the idea. I don't want to stand in front of my wife or my husband with something in my chest reminding me of the cancer. Some of my younger patients have said, I don't want to go swimming with this in.
Yes.
I don't want to play football with my son with this in. So I agree with you 100%. The data is very clear that there's no difference between the two. And therefore, it's really important to have a long conversation with the patient who's choosing an IPC and say, do you understand what this means? Every day of your life, this will be here. 3 times a week, you'll have to sit at home and be drained into a bottle in front of your family in your living room. It's an impact. I agree. So I've done most of these studies, but I'm not a promoter of IPCs. I think they're very equivalent. We need to be honest. I agree with you.
Okay, thank you. Second question, we don't have asbestos-free talc in Egypt, unfortunately.
Yeah.
But we have, I myself have studies on the doxycycline poudrage.
Yes.
Do you have, but I didn't do any comparative study. Do you have any idea about this?
Yes, okay, it's a very nice question. The lack of talc is a big problem. There is a very good meta-analysis in the Cochrane Library on different pluridesis agents published by Nick Maskell's group, so yes. Alex Dipper. In that, talc has the most evidence and the best evidence. You know that and I know that. but doxycycline is very good. It's up at 3 or 4. Now, doxycycline Pudraj, there's never been a randomized study, but doxycycline has been shown to be effective versus other agents like bleomycin, for example. The other one that comes up all the time is iodopovidone, where, because it's cheap and it's available. Again, I would strongly encourage you in Egypt to do a randomized study, because we need good quality data. If you like, I can help you guys, but to do one would be wonderful, because I think it's easy for me to preach from Oxford, you should do this, you should do that. And if you don't have access to talc, it's very silly. So, yeah.
How can I do the randomized study?
And then we can sit afterwards. We will sort it out, inshallah. We'll work it out. Yeah.
Honor of you. Last question. 10 or 12 years ago, I attended a workshop in Marseille with A-2, and he said that we may see in the coming years, that was 12 years ago, that the thoracoscopy will be in the context of staging lung cancer. And he said by word that I think that finding a single nodule in the pleural cavity does not, sure it will be different if you have a studied pleural study with nodules.
Sure.
But till now, neither the thoracoscopy nor any other tool got in the context of this.
Yes.
Do you have an explanation for this?
Yes, no, I do. Thank you. I think this is an important point. So I'm always surprised in my thoracoscopy practice, and Ahmed will agree. Sometimes you have a huge effusion, completely full, and you go in and there is one nodule.
Yes.
And then other times, the CT has said, tiny effusion, nothing to see, and you go in and it's peppered. And the reason for that is that CT is very good at looking at nodular tumor, as you know, but to detect the very subtle abnormalities at the edge of the pleural space is very difficult. It's a bit like asking you to tell me if there's abnormalities on the wall over there. It's very hard to see.
Yeah.
Now, it is true that even the smallest pleural effusion in the context of lung cancer increases your mortality, even if there is no malignant involvement. So there is something about early pleural effusion, even if it's small in lung cancer, that we don't fully understand. And my colleague in Glasgow, Kevin Blythe, is doing a study called Stratify, where we are taking patients with a T2, T2A, resectable lesion and an effusion, and we're doing thoracoscopy on all of them, and doing image-guided biopsies or thoracoscopic biopsies and a pleural inspection. So I don't have the answer yet. I have a personal belief, which is if you have an immune system within the pleura that cannot handle the cancer, I think that means you will have a worse prognosis.
Okay, thank you very much. Any questions?
I think for the sake of time, Dr. Najib is here. We can talk with him in the VIP.
I will stay here, no problem.
Thank you very much, Dr. Najib, for the coming over from the UK. We've enjoyed your talks, and I hope we'll see you again repeatedly.
Inshallah.
And now we have a small trophy for you.
Okay, thank you. Jazakallah khair.
احنا بس احب انوه عن انه احنا كنا عاملين اعلان انه في بعض المسؤولين من مصلحة الضرائب هيكونوا موجودين للي عايز يستفسر عن اي حاجة عن الفاتورة الالكترونية الجديدة. هم في الميزانين في البيزنس سنتر تحت، هيبتدوا كمان شوية.
وبعدين ما حدش هيحضر.
May I ask the chairpersons of the next session, Professor محمد عوض تاج الدين, دكتورة آية عبد الدايم, دكتور إيهاب ثابت, دكتورة ألفت الشناوي, and دكتورة سميحة أبو بكر